Well, good morning. It is straight at 9 o'clock, and as usual, we want to get started on time so that we can end on time. Good morning. It's August 25th. How did we get here? It's amazing. And to think that we've been doing these telemedicine echoes since April 14th. So I hope that it's been helpful and that we are providing information that is needed in order for you to expand or even start your telemedicine program. So thank you for attending. This is a partnership between the Heartland Telehealth Resource Center and the Missouri Telehealth Network. We're offering this echo for providers in Missouri, Kansas, and Oklahoma, and we address topics that include all things telemedicine. I'm Janine Gracie, Project Director for the HTRC, and have the honor to moderate these sessions. But before we get started, I'd like to ask everyone on the echo to make sure that your names are there with the state next to your name. So the way that you do that is you right-click on your picture or your name and then rename and have state the two abbreviation state. There we go. You're getting it done. Thank you so much. This helps us when we do the question and answer portion because, you know, sometimes the answers are different regarding whatever state that you are coming from. So thanks for doing that. And while some of you continue to get that done, we'll have the hub team introduce themselves. So let's start with Karen this morning.
Good morning, everybody. Karen Edison here from the Missouri Telehealth Network.
Thank you, Karen. And Evelyn?
Good morning. Nice to see everyone on the call. I'm Evelyn Nelson. I'm a telepsychologist at University of Kansas Medical Center and PI for the Heartland Telehealth Resource Center.
Thank you, Evelyn. Rachel?
Hi, everybody. Rachel Mutro with the Missouri Telehealth Network, the Show Me Echo program, and Heartland Telehealth Resource Center.
Thank you, Rachel. Robert?
Hi, I'm Robert Strauss with University of Kansas School of Medicine. I work with the Heartland Health Resource Center. Nice to meet everybody.
And Tim?
Good morning, Tim Davis with Oklahoma State University Center for Health Sciences in Tulsa and the Oklahoma rep for HTRC.
Great, thank you. And Heather?
Good morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS.
Excellent. Thank you so much for that. Normally, we introduce everyone on an echo unless we get to around 30, and we're just about there. So I think because we have such an interesting didactic today, I would like for you to introduce yourself in our chat. So if you wouldn't mind putting your name and your position and your organization and state you're from in the chat, that would be really helpful. And thank you for doing that. Let's see. So let's do some announcements before we get started. There happens to be a squirrel outside my window and my dog is kind of going crazy. So I apologize for that if you hear him in the background. He's in rare form this morning, apparently. So sorry about that. All right, for a more collegial environment, we always use first names on our echo. So those of you who are attending for the first time, we use names, first names only. And please be conscious of any confidential or protected health information that you may share. If you have a question, just be conscious of that. We don't want to get into any kind of violation there. We have in the past asked Joe Kingsbury for the questions, but we're going to change that up this time. If you have a question, just go ahead and ask that to everyone in the chat. We'll monitor those questions, and then also please feel free to just unmute your microphone and ask the question. We want this to be a real interactive echo, and so we just encourage that conversation as well. The presentation will be available on Box And also make sure that you just check box for any past presentations. If you have difficulty getting into box, let Lauren or Cece or myself know, and we're happy to help you out with that. You know, the value of Echo is in the cases. And so if you have a case presentation, if you have a question, or if you have, you know, some kind of scenario that you have developed through this telemedicine Echo, we would love for you to be able to present that as a case and then have a robust discussion with everyone so that we can all learn from each other during this Echo. So think about doing that. And I believe that we will get started with the didactic at this point in time. Today, we are honored to have Troy Lambert, who is Deputy Director of Primary Care Operations for Compass Health. And he's going to provide some information concerning the Compass Health response to COVID-19 and some lessons learned. So Troy, I'm going to let you take that away.
Good morning, everyone. Thanks for having me. Hopefully this information will seem very similar for those that have been dealing with COVID and how it affects patient care from primary care to behavioral health. I don't think anyone had a playbook for the best way to do really anything through a pandemic along, you know, and still maintain our patient care and that continuity of care. So I'm going to try to share my slideshow here. Bear with me for one moment. All right, hopefully everyone can see that. Again, my name is Troy. I'm a RN. I work with primary care, but I also collaborate with our behavioral health arm. For those of you that don't know, Compass Health is largely a behavioral health organization. However, we do have 12 FQHC sites that do medical and dental. And so we have to, work together as best that we can. We're also, one of the unique challenges is we were strung out between Kansas City, Missouri, and St. Louis, that we have clinics all through the central corridor between. So, in one location, it may be a little easier to do a response, but when you have 2,900 people spread out in that geographic region, it presented us some unique challenges. Initially, in February, when we first started looking at the end of February, we first started looking at how we were going to respond. The largest question that came from non-clinical individuals is how are we going to keep our staff safe? For our clinical, it was how do we take care of our patients? And so in the beginning, we had to kind of work through, I hate to use the word fear, but that's what it was, because without accurate information or education or good communication, those misconceptions of how things are going kind of creep up. In order for us to continue even any medical operations in the beginning, we had to very quickly turn to telephone visits and virtual visits. We were lucky enough that we already had a lot of telemedicine in our psychiatry department, and we were able to replicate that. But in order to take care of patients and see them, we designated one of our primary care sites in the eastern region, which for us was the most impacted by COVID. We're talking St. Charles County, right next to St. Louis. And so we used a combination, obviously, of telemedicine, telephone visits, and then we environmentally controlled one of our clinic locations where anyone with potential symptoms of COVID could actually go there and be seen. And I'm sure, as many of you know, in the beginning, we had a critical shortage of appropriate PPE. We found what we had on hand was close to 8 years old. And so to maximize the amount of PPE we had and our inability to get large quantities, we put together one site. And that site is where everybody, if you had any symptoms of COVID, that's where you went. Our behavioral health arm, they were able to just move directly into telemedicine, but it still presented some unique challenges. Our western region, which is much more rural, we did a combination. We utilized technology in either through doxyme or telephone calls where patients didn't have to come into the office to be seen. We would talk to them on the phone, do a quick assessment either for COVID or whatever issue else they had. And I'm speaking primarily from a primary care standpoint right now. And then determine, okay, you're safe for us to have you come in and see us. Obviously, we were all masked and everything else. Or it sounds like you need to be tested, and we arrange for that individual to come to the clinic but not come in. We would go out in PPE, test them, and move on. The biggest issue that we had, one of our first things to do was the struggle between being safe and segregating everyone and actually continuing care operations. And while you can do quite a bit with telehealth and telemedicine when it comes to primary care, there's a few things that you cannot do unless you're physically there. And so physical assessments, lab work, necessary lab work that you have to have in order to change medications and those types of things. And, you know, medications that we were providing for patients, you know, in the clinic, injectables and that thing. And so for the first probably 30 days, we really struggled on how we were going to do that. And we knew we had to provide that care, but how do you do it? How do you do it safely? And I think that was a struggle for a lot of folks. In the beginning, we did delay in-person follow-ups and lab work. And that we were able to do that basically by talking to the patient, you know, getting some information from them. But we also found out fairly quickly that there were critical labs that we had to have. We had, you know, Coumadin therapy and those types of things, and you can't adjust that without knowing exactly what that person had. One of the ways in which we first started to try to get people into the clinic is we would do a virtual screening on every patient appointment the day before. We would go through a list of questions, and that was done at the provider level. And so in order to, you know, have people comfortable with the type of assessment or screening that was done, we had our providers actually calling the patient the day before, doing a quick screening and determining if they were safe to come in. Now, obviously that wasn't 100%. COVID is such a strange animal that we've seen things we never had before. But everything was directed from the beginning. First, let's keep people safe, and then where do we go from here? How do we continue to deliver the care that needs to be done? And so we then moved into what we call our continuing response, because I'm sure you all know that it seems to change. In the beginning, it was changing daily, and it still continues to evolve.
Hey, Troy, I don't think your slides are progressing. We're still on the introduction slide.
Okay, I'm progressing them. That's odd. Let's see. Did it change now?
Yes, and then it's still in edit mode. I don't know if you want to put it in the slideshow mode.
Okay, I know what I did wrong here. Pardon me. I'm used to Teams. Zoom is a little new to me, so bear with me. Where'd it go? And now I completely lost it. Oh, technology is great. I think I actually closed out of Zoom. This is great.
You're still on here.
Okay. Bear with me. I promise I'm not doing this to cut down the time I have to talk.
Troy, do you want me to open the PowerPoint and I can just advance it as you go?
Yes, if you don't mind. For some
Sure.
reason, my computer is decided that it doesn't want to show anything.
Okay.
Now I'm back.
Okay, I'm going to share screen. Let's see here. Okay, can you see my screen?
Yeah.
Okay.
And then you'll need to put it in presenter mode, Cece.
Okay.
If you go in slideshow.
I'm trying to get my bar out. Okay. Okay, presenter mode. Present online.
Present from beginning. There you go. No, you want to click from present from beginning.
Okay, it just says from beginning on the far left.
Yes, click that.
Okay, I did click it, but it's not advancing. So then I'll just advance it myself like this as we go.
That works.
That looks like the same issue.
Do you have multiple monitors by chance?
I do, yes.
I think it's showing the wrong monitor for where the presentation is. There you go.
Okay. Can you see it? Can you guys
That looks
see it?
good.
Sure.
Okay.
Yep.
All right, and then which slide would you like me on, Troy? Very first or second? This is the second.
The third slide. Was gonna
Third slide.
be that. Yeah.
Okay, well,
So sorry about that. They don't keep me around for my technical abilities. So one of the things that we looked at was how do we get back to delivering care in multiple locations instead of one? And so with environmental controls, we closed all of our entrances except one that required every patient and every employee to come through the same door, which then helped with our daily screenings. And then with that, we created what was called a passport or a ticket to ride. Once you had that piece of paper that showed that you'd been screened, you were then allowed to go to whatever appointment that you needed. It also, for a lot of our patients who didn't have technology at home or internet speeds at home that was sufficient for them to connect electronically, we set up additional telehealth rooms, additional computers with DoxyMe in locations that we could easily clean, that were segregated away from most of our high traffic areas. And then we can still have patients come in and connect virtually even though they were on site. One of the big things that we found early on, just not outside of primary care, but a lot of our behavioral health clients, they were getting weekly labs for levels for antipsychotics and other medications, and that had all been put on hold. Well, that wasn't the best clinical medicine, so we developed ad hoc labs at doors where we knew nobody else was coming in, where we could control where people went, and then we could use the appropriate cleaning methods, be it UV, normal cleaning products. So that allowed us to quickly get back into making sure we were monitoring our patients either for their primary care needs or their behavioral health needs. We also use that as a temporary injection site for those in our substance abuse programs for Suboxone, if it was Invega, a lot of those medications that they're scheduled to get. And in the beginning, there was talk of switching a lot of the people off those where they've done very well into more of an oral medication, which would have been a regression. And so at every one of our sites that we had the appropriate people in the space, we set up these quote unquote free floating labs where we could continue to do that care. We could still see them virtually, but our physicians and our psychiatrists were getting the information that they needed. As an FQHC, we, in some of the counties that we're in, we are the only medical place there. And we received a lot of phone calls from health departments who were trying to meet their mandates and getting people tested when there was nothing available. So at 5 of our primary care locations, we set up an external assessment / swabbing tent. And so in the places where we couldn't do an environmental control inside, we set up mini exam rooms. It had everything that they needed: otoscopes, blood pressure scales, weight. We could do pretty much a full primary care visit there. Now, we tailored it to more of an express care open access model, and we could do testing. We could do nebulizers out there safely because it was outside, it was controlled, full PPE. This allowed us to provide care instead of having people go to the ER for issues that we would normally take care of in the office. So this ramp up went from about April till May, and there was a lot of logistics. How do you do paperwork? How do you get somebody signed in? And we moved all of that virtually. And so when a person called in and wanted an appointment, if they'd never been seen before, brand new patient, we were able to do the registration by either phone or doxing. Could email us information. We could copy it, take a picture on their phone and send it in. I'm sure most of you know we had to become incredibly flexible on how do we meet the requirements that we need for paperwork and getting people in, but how do we still see them? And so these external testing sites really helped with that. If there was any, like your consent to treat and those types of issues, we had it all out there. They could sign it and then it could go in. And so it kept that flow of patients where there may be a question if they're positive or whatever, it kept them outside, but it also allowed us to continue providing care for all things non-COVID. Because I think we all know none of the other disease processes stopped because COVID came. And so that was kind of our main focus. How do we continue care? During this time, we slowly transitioned back into seeing people in real time in the office. Again, screened by phone the day prior, screened at the entrance. If for some reason they had what we would call a positive screen, they had a few symptoms of COVID or had been exposed, we would just redirect them to our external, go through that. If they needed to be tested, we did. And then we turned their visit into a virtual visit with the provider. However, we still were able to collect vital signs and some information that our providers desperately wanted. We have not gotten rid of virtual visits. We have a lot of vulnerable population. And we found that for some of our folks that were an hour or more away from the clinic, we could still offer a telehealth visit in conjunction with, if they needed a lab or anything else, they could come by at a time that worked for them. And so we still do, I think 20% in primary care virtual visits. Our behavioral health is still primarily all telehealth. And so that flexibility has allowed us to see patients and meet them where they're at, which, right now you have some people that don't even want to come into an office because they have a concern. And whether, it's not to say that their concern is valid or not, but we're still, if we didn't provide this other option, more than likely they would not continue to get care. And so that's kind of an option we didn't want to go with. The biggest thing that we found with doing some of this, especially with the testing with the health departments, we've worked with, I think with our location, we have about 15 health departments. And one of our real struggles with, they all seem to have a different outlook on what they wanted to do in their responsibility to COVID. And so that was, as we were doing this and trying to provide care and be an outlet for our communities, not just our patients, we struggled with we couldn't do a consistent across the board. This is how we work with health departments because they were all different. Their resources were different. Unfortunately, in many places, politics came into play for finances and the other. Next slide, please. And so lessons learned, I think our biggest, obviously, for us was we assume that most of our primary care staff understood PPE. And we were, I wouldn't say shocked, but we were surprised at the number who did not know how to properly use PPE, putting it on, taking it off, what to use when. And so because we couldn't run around and train everyone individually again or retrain them, we used Teams, much like Zoom, and we did didactics with them so that they could watch somebody take it on, take it off, how to get, rid of it. And in the beginning, everybody wanted to be in like full PAPR's gear when it wasn't necessary. And so outside of just training them how to use it, it was also training when to use it, what is proper, and that you don't need a full PAPR's gear to, talk to somebody that they're 6 feet away if you're not doing an aerosol generating procedure. Procurement of the appropriate and effective PPE was not in the hands of clinical staff. And so when we first started our procurement, doing the best that they could, they thought they did great by getting us, 1,000 N95 masks. Well, turns out they were level 3 surgical masks. And so we had to switch how we did PPE and inject more clinically minded people that had a background in working with this to get the right PPE. And I think, not having the correct PPE, while you'll have, I know medical people will go and do whatever, not having the correct PPE, we've seen it time and time again. Our responsibility and mine was to make sure that they had what they needed. And so putting a clinical person back into that really assisted. And again, our education for our at-large staff or non-clinical who didn't understand the difference between an N95 or a surgical mask, or why you need a face shield or when you need a gown. And so because we hadn't done that beforehand, we found ourselves behind the curve and trying to get that information out to people, almost 3,000 people in a very timely manner. Our second lesson learned, and we did this very early on, you cannot replace clinical knowledge and expertise with anything else, in my opinion. And so we wanted to leave the decision-making when it came to how to see patients, what we needed to do, how to continue patient care. We wanted our clinical experts, our psychiatrists, our physicians, our nurse practitioners, our therapists to be involved in the deciding of what we did and how we did it. In the beginning, everybody was in our administration staff was reading the news and getting all of this information from sources that may or may not been correct. And I know that, the WHO and the CDC has had differing information. It's changed, but it's still, and still a better source of information than just what you would get on the Post or anything like that. And so the very first time we had a positive patient that we knew was positive that had been in a clinic, part of our administrative team wanted to shut the whole clinic down for 14 days. And I saw some eyes go up, and that was my reaction. And we, by getting that clinical and our medical directors to come in and say why that's not appropriate, why we can't do that, is what helped us switch from a mode of being overly cautious to having a standard response that mitigated the risk, didn't eliminate it. You can never eliminate risk. We did the same thing when it came to testing. A lot of the guidance in the beginning said you should only test this group of people. However, we were finding in performing tests, which at this point between, I think the middle of May to now, we've done over 8,000 COVID tests in our clinics. We were seeing a difference of when somebody was positive or not. We were seeing a lot of asymptomatic patients that had had exposure, who then those individuals worked in industries where you needed to know if they were positive: residential, long-term care, security, nurses, law enforcement. And so we utilize more of our clinicians' judgment on how and when to test. And one of the big things, again, was that continuity of care. And we knew we had to take care of the patients. And it was just a difference of how. And by making sure that our clinical leadership was involved in the decision-making, we made sure that these decisions weren't made in absence of clinical expertise and knowledge. Our biggest struggle in the beginning, and even to this day, I still have to go out and have conversations with people, was that initial lack of knowledge and administrative guidance, because we didn't have any. It's a novel virus. And so we had a lot of fear, we had a lot of anxiety. We had people that did not feel that by us having patients come to our location, even though it was desperately needed, they thought that we were putting our business over their safety. And we could have done a better job in the beginning of explaining how and the why to a large group of people than what we did. And I think communication has become important. One of the issues that we had is when we did have a positive employee, there was a lot of discussion on who do we tell and not tell. And we decided on, from the clinical perspective, you cannot hide anything from anyone. Let's just be honest and tell people so that they can make decisions for themselves, be tested if they'd like to, quarantine, all of those things. And so I would say the first 30 to 60 days, we didn't do the best job that we could on educating our patients, and then also letting them know when an incident had happened. That's my doorbell. I apologize. And then again, that just leads to communication. Bear with me for one moment. The joys of working from home. And the other thing that we learned very quickly was how to develop a communication system, who needs to be that person that gives it out. And then, making sure that gets to everyone from supervisors on down on what our response is, how we're doing things, from HR to clinical. It became just very important that we made sure that we had the right information in everybody's hands. Next slide. And so external partners, I'm not sure of the audience, but as an FQHC, we're called upon a lot of times to participate either with the local health department or the feds or our state association. And one of our struggle was with the local health departments not knowing what to do and how to respond, and not having the resources to provide testing or education or information. A lot of times what we would tell patients if they came to get tested was it was not congruent with what the health department was saying. So we had two groups of medical professionals, if you will, giving our communities differing information, which caused some anxiety, caused people to not know what to do. And so we had to make an effort to contact each individual one in an area and to kind of discuss how we're going to go about this, especially those counties where we're the only people testing for them. So the other part about that is we decided from the get-go not to give release notes to individuals when it came to COVID. We simply put on a sheet positive or negative in the CDC and local county guidance. We get demands every day of people wanting to have a note that says they're clear to go back to work, and we cannot really do that 100%. So that's kind of where we've gone. We also found that some counties wanted every single test we did. Some wanted only positives. Some wanted positives and then negatives. The states struggled to kind of get the reporting piece, placed some fairly inconsistent demands on us as clinicians and in our testing sites. The other piece that we have done, because we've been asked and we're an FQHC, so the Department of Mental Health and Department of Health and Senior Services has leaned upon the FQHCs to provide testing for the long-term care facilities and the residential and those types of locations. And one of the things we wanted to point out is when all this discussion going on, they talked about pay and they talked about, how to do it. The piece we found from people who are not clinically had that clinical mindset is they didn't understand that every lab has to have an order. And as a provider, if you order a lab, you're responsible for that, even if you never see the person. And so we helped develop with the DMH an MOU that covered every aspect of kind of this arrangement that we had. we brought this up and people didn't seem to think it was a big deal. However, our physicians and nurse practitioners did. And so there's an MOU that was developed if you have to test people in an external facility. And it clearly states there's no patient-provider relationship. You know, it talks about costs, it talks about responsibilities and reporting. And so I would strongly encourage, if anyone's being asked to, you know, assist with testing in a facility that's not connected with your own, to, you know, look at an MOU that we have that we can provide or give and tailor it to your needs. Because many times what would happen is after we do the testing, they would start calling us saying, well, you need to come in and see all these patients. We're like, we never established a provider-patient relationship. The MOU clearly states, and this was, you know, covered by the state. So there's a lot more that, you know, we could go into. There's a lot of nuances, but really those are the key things that we took away from our initial COVID response to where we're at now. And again, it's changing daily. I just saw where the CDC removed the quarantine for travel. And so we try to keep up with that. I thank you for your time. I don't know if I'm supposed to answer questions, but that's all I have.
Yes, Troy, thank you so much for that good information. We're going to open the lines up now for questions, and please feel free to ask your question. Raise your hand and I'll recognize you and you can answer or ask your question, or you can ask the question in the chat as well. And Troy, I had one question. What was the experience with telemedicine prior to COVID and then as it stands right now?
So with telemedicine prior to, for our behavioral health departments, I think we were one of the largest telehealth providers in the state for psychiatric services. It was unheard of in primary care. We had talked about it, you know, in work, but our providers always, and I don't disagree with them, felt I can't do as good a job as when I can see the patient. And so it's like, okay, what happens when we take that out? And so we initially started it with four of our 30 physicians and nurse practitioners who had a really strong base with technology. As soon as we were able to get everybody kind of experienced to it, they really took to it. Again, we had some limitations and we had to be flexible to get those, but I'd say it took us about 2 weeks to get all of our primary care physicians and nurse practitioners to using either the telephone or the telemedicine. And now I have some that don't ever want to let it go, which is fine. I mean, I think it's something we need to use. But for a group, and I'm an RN at heart, if I can't see and touch a patient, I couldn't figure out how I could do that assessment. And it was a learning process. And we had the providers come together for a 15, 20-minute phone call on Mondays and Fridays, just to kind of give information about, hey, I found this worked, or I found this didn't, or how are you all doing this? Because when they were able to collaborate with peers, they felt a little more comfortable with, you know, taking that next step if they hadn't done it before, or, you know, seeing a patient with this type of disease process without being able to have them there. And it was that integration and that collaboration from like-minded individuals that did more than anything I did in trying to get them comfortable for telehealth.
Thank you, Troy. Appreciate that. Any questions, comments?
Hi, Troy. This is Tim from Oklahoma, and I apologize if I missed, but are you using a fully integrated telemedicine platform, or are you just kind of using a video conferencing system and then using your EHR? Or
we're using the split. We use NextGen, and it is not set up to integrate with DoxyMe. Our behavioral health uses my avatar, and they're working on that, but currently it's not. We went with DoxyMe only because it was the ease of use for the provider and the patient is very nice, but no, we had to get everybody up on 2 screens where they could have DoxyMe and their chart up. It'd be nice, but no, we did not have that. Still don't.
Great, thank you.
Troy, I apologize if I missed this, but can you describe how you prepared the patient? Was there certain things you all talked with the patient about ahead of time, or things that you recommend?
We did. I can, from the primary care point, then I'll talk a little bit about, because I worked with our outpatient therapy director. It was a switch for them. We would contact the individual the day before. And that's where either our nursing staff or our nurse care managers would have the conversation with the patient. And it came down to, we want to continue your care. Right now, our clinic is not open to having you come in. However, you're going to be visiting with your doctor, with your nurse practitioner by phone. You're going to be able to ask questions. And we allowed for the appropriate amount of time, where sometimes it would have been a 15 visit. In the beginning, we made them all 30. Because it was new and because there may be an issue with technology, but mainly to make sure that that patient felt that they got everything that we could possibly give them from the visit. And then it just kind of evolved. If we just, if the patient wasn't comfortable or we didn't feel we were getting what we needed or they needed, we would work to get them in. And then a lot of our physicians would have that conversation in the room with the patient. Look, I'm concerned about you traveling. This is what we're going to do, how we're going to, and so there was a lot of explanation. Our biggest struggle did come into those that were unable to, that didn't have the technology at home. One of the things we did is at all of our locations, we put free Wi-Fi on the outside, and then they could come in and make sure they had a connection. So, and if there was a problem, we were right there. Our behavioral health, they were pretty used to it in the beginning anyway. So it wasn't as much of a transition.
Thank you.
Hey, Troy. I have a question. I've been getting this question quite a bit from people that I have been talking to about, people that are starting their own telemedicine service. And it has to do with the ability to gather like vital signs on telemedicine visits. And so I just wondered how you guys did that so that you were able to, record them in the chart and things like that. So we've heard that sometimes if someone has a home blood pressure monitoring system, then they take their own blood pressure, or they can take their own temperature or get their own weight and report it to you. And I wondered if you guys were doing any of those types of things.
We did, and we continue to for some of those visits. In the beginning, it's a struggle. One, on the telephone, it was a little harder because what we would like to do is actually see them when they did the blood pressure and view the machine. Blood sugars, we'd have them take those and report it. So in the beginning with telephone, we went with less information on the vital signs than we would have had. And so as we progressed into the DoxyMe, we were able to see some of that. We also identified those patients that it was crucial that we had correct vital signs. Anyone we were starting on blood pressure medications or we're in the middle of transition for insulin. And so we I guess scraped, begged, borrowed, and stole any equipment that we could get. And we would provide that to those really critical patients so that they could take that and then report it back to us. Not everybody had that ability. When we felt that we had to have a very good set of vital signs, we'd ask them to stop by one of our labs that was, one of our floating labs, come in, have that done and go. They could do it at their convenience. We kept them safe. And so it was kind of all of that together. We let them self-report. And then I know we attempted to get through one of the grants, some of the, can't remember who the company was, where they had the blood pressure cuff that'll actually report it up to a portal and those types of things. We didn't get that grant, but we're going to continue to look at that, doing it in the future.
Thank you. One more question on the DoxyMe product that you're using. Are you guys using the totally free version of that? No, we did in the beginning just to make sure that it worked. However, because our behavioral health department also liked DoxyMe, we went ahead and I believe did the enterprise version.
Great questions. Thank you.
So I just thought of something when we were talking about preparing the patient and getting patients comfortable. Years and years ago, we did a study on our communication patterns in telemedicine versus in person. And you guys all might be interested. Everything was the same except for one thing that really stuck out, and that was the use of small talk. So we did a lot less small talk in our telemedicine visits than we did in person. So because we learned that, we started being very deliberate about using small talk, or injecting some normal small talk at the beginning of the visit, like we do it in person. So I just thought I'd mention that.
That's good information, Karen.
Dr. Edison, can I follow up on that? Did your patients like less small talk, or they really wanted the small talk? Because we actually found some similar things, and some patients appreciated the lack of small talk and that they got in and got out more efficiently. I think it probably varies, but what was your feedback on that?
I think patients, we got a better response when we started treating them just like we did in clinic. And again, it's, you always tailor your care to the patient, right? We do this instinctively as healthcare providers. So, I have an elderly person at home, like I might spend more time asking them about their dog, or, what they're doing, or their garden, or, you know what I mean? But that happens so much so that my residents used to tease me that when I saw patients from Southern Missouri, that I would start having a drawl, like a Southern drawl, like I'd start, like using the same accent. So I think we just do that naturally a little bit, but we tried to inject more small talk, and I think it went better.
That's excellent. I just actually talked to a health center in rural Kansas that needed some iPads for their patients at home because they were doing the telemedicine from home, and they worked out a deal with their school district to get their older iPads, okay, for like $50 a piece. And that made the school happy, it made the health center happy, and actually they were, just fine for the work that they were doing. So don't, if you need that equipment, think about your school districts. They may have some surplus equipment available that would help out the telemedicine program. So I thought that was really cool.
And if I could add to that, we went to the schools, but we also went to local agencies and churches and asked for, if you have any laptops or iPads or any device that you're not using and want to get rid of. And we were able to garner some quite a bit of material in our more rural areas for something very similar. Our IT department just kind of took it down, preloaded the software needed, and then it was just kind of a donation. So, I mean, it was everything that you could find anywhere.
And I will just add on to that and mention that Missouri Telehealth Network is currently partnered with the Missouri Department of Economic Development to get about 12,000 or 13,000 hotspots out to patients of federally qualified health centers and community mental health centers, which, where Troy works is both of those types of entities. And so if you know anyone at those types of centers in Missouri, you might ask them if they're participating in the project. We're trying really hard to get 100% participation.
That's a great service. Thank you, Rachel, for sharing that. Any other questions? Oh my gosh, well, apparently the squirrel has now appeared again. Of course, every time I talk, okay, so I feel your pain, Troy. This is, so anyway, well, listen, thank you so much, Troy, for your informative didactic today, and we hope that, yes, that we will be able to see you again sometime and learn more from you, from your experience at the FQHC. Those FQHCs tend to have a lot of questions for health resource centers, so we understand the pain that you've had to go through.
No problem. I appreciate you having me. Hopefully it was informative, and I think we all see we've all had to kind of evolve and be flexible. And so I'm actually headed to swab. So I'm going to a local testing event. So I will sign off, and thank you for your time.
That's great. Thank you, Troy. And so everyone else, right now we still have our telemedicine echo scheduled for the Tuesday after Labor Day, which is September 8th. We are working on a speaker. We're hoping it will be HIPAA compliance in the age of COVID with telemedicine. If not, we may give you a break, but please stay tuned and watch your emails and to see what's next. We have some great speakers up in line for you already, from workflow plans to working with pediatrics and telehealth. I think that this fall you're going to learn a lot from the speakers that we've got lined up for you. So stay tuned and go out and make it a great day. Thank you.